The topic of our next plenary is that. Before I introduce our speakers, please remember to use the index cards in your folders for questions. Questions will be taken immediately following the presentation. Our speakers today are Dr. Donald Rosenstein and Dr. Leeza Park. Dr. Rosenstein is a professor in the departments of psychiatry and medicine at the University of North Carolina at Chapel Hill, where he is director of the UNC Comprehensive Cancer Support Program. He is also director of the Division of Hospital Psychiatry and the Psychosomatic Medicine Fellowship, training director in the Department of Psychiatry. Dr. Rosenstein's awards include the NIH Director's Award and the NIMH Director's Career Award for Significant Scientific Achievement. He is currently director of the Live Strong Center of Excellence for Cancer Survivorship at UNC and past president of the Academy of Psychosomatic Medicine. And Dr. Leeza Park is an assistant professor of psychiatry at the University of North Carolina School of Medicine and a member of the UNC Comprehensive Cancer Support Program. She completed her residency training at the Harvard Longwood Psychiatry Residency Program and Fellowship in Psychosomatic Medicine at Brigham and Women's Hospital, Harvard Medical School. Dr. Park's clinical and research interests include the effects of illness on parenting and families and the supportive care needs of patients living with advanced cancer. Please give me a warm welcome to Dr. Rosenstein and Dr. Park.
Okay. Can everyone hear me? Okay. All right. Well, thank you for the introduction. First of all, I just want to say it's an incredible privilege to be here today, and it's very cool just to see everyone here. What we're going to be talking a little bit about today is about psychological adaptation to metastatic breast cancer. And this is not to say that I'm any expert in this, but part of my job, or actually a great deal of my job, is to actually work with people who are struggling with some of the emotional aspects of this disease. And I'm not here to tell you how you should be thinking or feeling or reacting to this, but I'm hopeful that together, we can talk about kind of what is helpful and what can be done. So I'll talk a little bit about what is known about living with metastatic breast cancer, talk a little bit also about what we don't know, which is a lot, and finally focusing on some of the strategies that can help us in terms of how we psychologically adapt to a different life than we imagined. And Dr. Rosenstein, who will be speaking after me, will be speaking about this a bit more in detail. So when I first looked up the definition of adaptation, this is the definition I got. It was thoroughly unhelpful. I think it was off of dictionary.com or something. It was like, oh, it's obtuse. So then I looked a little bit more. Oops, well, I got too excited there. A little bit more of a better definition here, which is one was to change your behavior so that it is easier to live in a particular place or situation, or to change something so that functions better or is better suited for a purpose. And I felt this was a little bit more applicable and relevant. And the idea here is that when someone receives a diagnosis of metastatic cancer, it is not a single event in time in terms of how you adjust. You're not unadjusted one day and adjusted the next, but rather it's a process. It's a series of coping strategies that one uses to deal with the ups and downs emotionally of this illness, of the problems that come up, and of the uncertainty and unknown. The other thing about adaptation is, this is a slide I stole from a dear friend of mine, Liz Sherwood, which is the idea that the same stimulus over time in adaptation produces a different response. And that is that the diagnosis doesn't change, and some of the stressors may not change, but the way that you experience it or how you feel about it can. And that, fundamentally, that, when we're experiencing, that this is hard, because you're experiencing something you've never before. And when we're presented with new challenges, there are times when the strategies that we used before may not always apply or may not work as well. And so I'm going to talk a little bit just about what some of the common concerns are. And I'm not going to go into a big list of this because it'd be really long, and I'm not sure if that'd be very helpful. But certainly, what are the things that patients with metastatic cancer worry about? What happens to them? So I think first and foremost is the fear of progression and uncertain future. I think it sometimes can feel like it's hard to plan for the future when you don't know what's going to be happening next. There's the idea that there's tolerating the physical symptoms. So the fact that, really that there are real impact in terms of how you feel physically. Changes in how you look and how you feel about the way you look body image-wise. And although no one ever talks about it in a cancer center, that there's changes in sexual functioning. And then finally, some of the, what I'd say, effects on loved ones and caregivers. The idea that if your significant other, your parent, your children, your parents aren't coping well with this, then it's hard for you as well. And then finally, the existential concerns regarding mortality and how many of us have the luxury of not having to think about this on a daily or regular basis. But when you get this diagnosis, it does make most of us have to confront that at least a little bit. So when I was initially putting these slides together, which was very last minute, I will admit, I was initially thinking about, well, why don't we look at and put some slides on what it's like to cope with breast cancer in general? Because as you all are aware, it's the most common cancer in women. There's been, therefore, lots of studies that have looked at kind of psychologically how do people cope with this disease. But then I kind of realized that, looking at this and the lessons learned from, patients who've experienced kind of earlier stage illness may not always be as applicable when you have a stage 4 diagnosis. And so then I thought a bit more and realized that perhaps what might be more applicable would be the idea of looking at how do people live and cope with a chronic disease, right? And because of all of the amazing discoveries, some of which Dr. Carey and others have discussed, is that the reality is that most women and men who are living with metastatic breast cancer are going to live for years. And so therefore, the quality of your life really starts to matter. And before I go further, I will say that when you think about coping with a chronic disease, everyone experiences distress. And if you're not experiencing any distress, then I'm worried about you, but in a different kind of way, right? So keeping that in mind, up to a third or even a half of people are going to experience really high levels of distress. And yet, despite that, despite recurrences or changes in treatment or changes in your functional status, that most people actually find a way to adjust quite well. And I think that's really remarkable. And I would ask yourself, or if you look around the room, when you think about how you felt the day that you got diagnosed versus how you're feeling today, I imagine that most of you would say that there's a substantial difference. And I think that's really important because it speaks to the underlying just resiliency we all have as people, that despite whatever gets thrown our way, that we all find a way to reach a new equilibrium. And the other reason why I bring that up is because even though symptoms or feelings like depression or anxiety are normative parts of this experience, and I hate the word normal versus abnormal, but if everyone is experiencing some of those depressions, and it probably is part of it, then it is, I guess, normal. But the idea that that's a normative part of experience, but severe anxiety, out of control anxiety, depression that keeps you from getting out of bed, that's not an acceptable thing. That's not a part of the normal chronic disease. And I tend to get all bent out of shape when I have patients whose sometimes they're doctors or primary care doctors. I had a patient, I think, 2 days ago who came in whose primary care doctor told him, well, of course you're depressed, you've got metastatic cancer. And I got all worked up because I don't think that's the case at all. And in fact, if you look around the room, it's not the reality. So when you think a little bit about adaptive tasks and what kind of things are helpful, there's lots of different data about kind of what helps and facilitates adaptation. But I decided just to narrow this down to 4 things. And the reason why I put these up on there is because there are things that an individual can do or can help promote. And the first one may seem a little bit obvious, which is managing the physical symptoms of illness or treatment. But I mean a bit more than that. And what I'm getting at is the idea that, just one of the ways to help adapt to this illness is to continue to live and seek an active life despite the physiologically induced consequences of illness and its treatment. And that it's really hard to feel good psychologically if you're feeling bad physically. And it's certainly possible, but it means that the first step in kind of psychologically adapting is being as aggressive as you are with your treatments about managing all the other needs of your pain, your fatigue, your nausea. And that has real consequences in terms of how we feel emotionally. The other thing on here is called emotion regulation. And what this gets at is the idea that, data and studies have shown that people who adjust better to a chronic illness or disease are the ones who have some means or ways of expressing or acknowledging the emotions that they feel. And it's not to say that denial doesn't have its place, because I think it does. If you were to think about the enormity of everything every single day, every minute, it would be overwhelming. But that for all those moments, you also need places or times where you can also kind of have a way for yourself to process the emotions that you're feeling. And I am obviously very biased because I'm a shrink, but I think that talking is one way to do so, but it's certainly not the only, right? But clearly, something like what the MBCN and other groups are so amazing about is it gives lots of different ways and forums to do so. There's online, there's through Facebook, there is in person, there's conferences, and that really, really matters. For breast cancer in particular, for metastatic breast cancer, there have actually been good studies, rigorous large studies that actually have demonstrated that group support is associated with better outcomes, with better quality of life, with less depression, with actually reduced pain. And I suspect it has something to do with this idea of emotion regulation. And the reality is that I don't think everyone needs to see a professional, but you need some outlet to help to help you make sense of these emotions. If you just think about, if you constantly are ruminating or thinking just internally about all your worries, your angers, your fears, and there's no outlet, then there's no real place for it to go. The third part is self-management, and this is the idea, it's actually kind of a medical term, but the idea is just because you get breast cancer, it doesn't mean that you stop brushing your teeth and going to the dentist, right? Maybe you can for a little bit, but then you got to pick up. So the idea here is that all the other things that you do to help manage your illness and to help manage your life kind of holistically and really matter and have a real impact. So those are things like how you exercise and how you eat, how you take your medications, how you make sure that there's other things that are not getting in the way. And there's been, most studies have shown that poor self-management is really associated with kind of poor psychological outcomes or adjustment. I don't think there's been enough studies or data that really shows that good self-management leads to better outcomes, but I think that's what's needed. And then finally is this kind of fourth category here, which is a little broad. It's called positive cognitive strategies. And what I mean by that, and what Dr. Rosenstein will be talking a bit more, is the idea that it's not just trying to minimize the negative aspects of things in life. It's also really seeking out the positive. And this is not to say that you should always be thinking positively about your illness. That's not what I mean at all. But the idea that you need to find somehow, some way, the things that are still meaningful to you and in your life, things that are going to bring you joy, that make you happy, and that you have to actively seek these out. That these strategies that for how people do this are going to differ through everyone, but that this needs to be a way, to be a priority. And sometimes it means shifting the way that we cope with our lives, and maybe it means finding readjustments or kind of redefining what can be a success or a good day, but that we make this a priority. There are things that help facilitate adaptation. I'm trying to not talk too long because I want you guys to hear more from Dr. Rosenstein. But the idea of managing expectations so that you yourself don't become your own harshest critic, or the person who's most frustrated is actually the person with yourself. And then two, the idea of finding meaning, which is something Dr. Rosenstein will be talking a bit more about. And then managing the loss of control and also coping with the uncertainty. And I wish I had a magic tool or trick here to tell you about how to manage those last two. But the reality is that most people find a way that's going to be individual, and whether it's by focusing on the present, whether it's setting smaller goals, of trying to normalize what you can, that everyone finds this way, but that this is one of the keys to help facilitate kind of adaptation to this. That being said, there's lots and lots of gaps in our knowledge. And what I really want to emphasize is I think that this is the time now to have a research agenda, and this is why as we both talk, I want you to be thinking about this, really that we don't know enough about how to enhance and improve the quality of life, the psychological functioning, the supportive care needs of men and women with metastatic breast cancer. And this is where we need people like you, because without individuals saying that this is important to them, then it's hard to really do data-driven research to figure out kind of how do we help accomplish that. The other things that we don't know are how to best support the partners and children and family members. I think we still are doing, it's on a very early stage, but looking at what are the strategies to promote resilience, which is the idea of kind of bouncing back after a trauma or a negative life event. And then finally, something that I'm particularly interested in, which is the non-patient roles and responsibilities. And what I mean by this is that well before you were ever diagnosed, you were a mother, you were a parent, you were a spouse, you were a daughter, you were a best friend. And those roles, those identities, don't stop because of this illness. And they indeed may be changed by this illness and vice versa, but this is going to affect who you are as you go through this journey. So if you're going to indulge me for a couple minutes, I'm just going to talk about a small study we finished here at UNC. And it was called the Fathers and Mothers with Cancer Study. And what we did is we actually identified 63 patients, all who had a stage 4 cancer, many of them who had breast cancer, and all were parents of a dependent child. And by this we defined as someone younger than the age of 18, though I think we can all agree that if you have a 20-year-old who's still living at home and you're very worried about them, they're probably still dependent. They could be 30 and living at home, you're still worried about them. But for this, just to make it clean, we said 18. And so what we did is we had them fill out a whole bunch of measures, and they were very gracious to do so. And these really in-depth interviews that I think on some cases even lasted up to 2 hours. And really what we were trying to get at are kind of what is the impact of your experience, your identity as a parent on your experience as a patient and vice versa. Kind of what were the biggest sources of distress and how are people coping with it? Because really when we look at these studies, how we learn how people cope with this illness is really to talk with each other. And finally, to find out kind of what we can do from the cancer hospitals, from professionals, and from each other. And briefly, kind of what we found were that clearly there's still a lot more we need to do. There were really high levels of worry in this group. And so as a clinician, I say here and go, then this is something we're not done yet. We still need to work on this. And that there were little high levels of worries of other measures of psychological distress. However, what I was really struck by was how much that everyone in this study managed to balance their role as a patient and as a parent. That I would say for the vast majority of the individuals in this small study, their role as a parent greatly impacted their experience and as a patient in going through this. And yet it wasn't necessarily clear to me, or that at least they weren't saying, that they were necessarily communicating that to their providers. And when your role as a parent was one of the key defining features of how you made decisions about your treatment, or where you were going to go for your therapies, or how you coped with this, that I actually think one of the gaps is here is making sure that our patients are actually letting their treaters know this. And the other thing that really came out was how, being a parent or having a child was not only the greatest source of worry, but also, importantly, probably the greatest source of meaning and benefit. That despite the craziness of this diagnosis, that having your child and identifying as a parent was incredibly motivating and a source of strength. And that this is really important when I think about how do people cope with this. And with that being said, I'm probably now just going to transition over to Dr. Rosenstein, who's going to talk a little bit more about how people find these benefits and meaning, perhaps even when they don't have kids. So.
How lucky am I? I get to work with this bright woman every day. So over the next 10 or 15 minutes, my job is to bring coals to Newcastle. My fundamental message is one that I think you already understand by virtue of being here. I've been here since the start of the conference this morning, sitting in the back, and I've been deeply impressed with a number of things, including, not unimportantly, how connected and purposeful this group of people is. And that's really the bottom line message that I have today, and I'm going to go through it in a couple of different ways. This is a picture of the clinical center of the National Institutes of Health. And this is where I spent the first 20 years of my career. And preparing for this meeting, for this talk, was really interesting for me and difficult, quite frankly, because it involved an acknowledgement that most of the questions, most of the struggles that you have are ones that neither I nor Leeza nor most healthcare professionals have definitive answers to. So it's hard to kind of prepare for a talk when you really don't know the answer to the question. But it did serve as an opportunity for me to really take a giant step back, get a little philosophical, as it were, about kind of what this is all about. And so that's what I want to share with you over the next couple of minutes. So for those of you who don't know, this is, I think, one of the best uses of our taxpayer dollars in this country. So the NIH is about a $35 billion kind of infrastructure for biomedical research and psychological research and developmental research. And the clinical center is about 10% of that budget, and that's where a lot of the translational research goes on. So everybody who walks into this building is enrolled in a clinical research protocol. So one of the things that I was so pleased to hear this morning is the call for more studies, more participation, more input from patients and family members into what kinds of questions are asked and answered. And as you might imagine, there is a lot of what I call in the business institutional transference. People come here with rare diseases, with bad illnesses, with refractory illnesses, and there is a great hope that this is going to be where you're going to get cured or your life is going to be prolonged and so on. So one of the things as a psychiatrist working in this space that I experienced time and time again was this inherent tension between hope and facing reality about a difficult situation. So one of the first things I wanted to do, I don't know where Shirley is, but right out of the gate this morning, she kind of alleviated a worry of mine, which is, about can I go there talking about death? And clearly I can, and this is a very eyes wide open crowd, and so I'm going to talk some about that. The other thing I want to mention before I leave this slide is to underscore something else that Shirley said, because you really got to sit with this for a minute and think about it. She talked about what happened in the late 80s with respect to HIV/AIDS. In my career, I lived through this. So I was finishing medical school in the mid-80s when AIDS burst on the scene. And for a good long while in the work that I did doing psychiatry for medically ill patients was working with patients who had full-blown HIV/AIDS. And a lot of patients died. And it was unthinkable for a long time that it could become more of a chronic disease. And it did. And I saw that happen during my time, in particular at the NIH, where I did a lot of studies with this patient population. So how you have what was described earlier is realistic hope, realistic optimism. There are a lot of different kinds of hope. And living forever, I'm afraid to say, isn't one of them. But there is reason to believe that with a very focused, powerful research agenda, there can be dramatic changes in your lifetimes. I was really moved by that exercise of everybody standing up earlier. And so I want, as I talk about mortality and death, I want you to keep that larger picture in mind. So this is a slide that you don't need to pay attention to the details. This is a graphical representation of the longitudinal course of someone who has bipolar disorder. And this was one of the methods that was developed by a mentor of mine there named Bob Post called the life charting method. And the reason I put this up here is that this was very important in my own thinking about my clinical work and research work, which is to take a step back and to say, when you look at something outside of an episode right there, you can understand things about it that you may not understand otherwise. And what we've learned about bipolar disorder is that there are different patterns to the recurrence of different episodes that help guide how we think about it and how we manage it. And so if we think about this from even a broader perspective, that each of us has our own unique life trajectory. There's a beginning, there's a middle, and there's an end for all of us. And that's true whatever you're living with. And along the way there, this is an incomplete list of some of the important things that happen. And certainly what happens along the way is that there's a lot of really good stuff and some awful stuff. And this is what contributes to the unique trajectory that I'm talking about and what I'm deeply grateful for all of my patients. There's a couple who are here today that I've seen, and in particular have helped me kind of appreciate this on a deeper level, is the individualized contributions. We all bring an antecedent context to our lives, to our illnesses. How did your favorite grandmother die? How did kind of your teaching and the modeling within your family go with respect to responding to illness, responding to adversity? Everybody's got their own story, which is why it's so hard to kind of give an answer to the kinds of questions. How do you live well with metastatic cancer? Well, it depends. It depends on who you are. It depends on what matters to you, and a number of things that I'll talk about in a minute. And if you'll allow me, I want to get personal for just a minute, because this thing right here, we've all got various traumas that impact on our initial intermediate and longer-term responses to things. And so here is a family photograph. This is my son, Kobe, when he was little. This is him at age 21, my wife and daughter and I. And it was a bit of a risk for me to think about talking about autism to a group of people who have metastatic cancer. I understand that these are not the same things. But there's a core psychological notion that I think is relevant, and that is that what happens with news that's difficult news is that it changes our imagined future trajectory. My son did not die. He did not have a brain tumor. He's alive and wild and well. And if you notice here, there's a hand on his arm by his sister, on his belly by me. He's a fast-moving guy. He's got pretty profound autism. So this is like a rare photo capturing our family in the wild. It's not easy. So he did not die. But what did die was my fantasy about what kind of life I was going to have with my son. And I mourned the loss of that imagined future. And it took me a while to reimagine a different kind of life. And I think this is true whether you have metastatic breast cancer, whether you have Sjogren's syndrome, whether you've had a divorce that tore your heart out, whether you had a personal bankruptcy. I think this is what happens in life when life happens, is that we have to rethink what really was never promised to us in the first place, what's going forward. And that is the task of what happens between here and here. And so, as we saw this morning, for many of you, you were diagnosed with metastatic cancer when your breast cancer was first diagnosed. For other people, there was a period of time in between. And this is really the question. And what has been so interesting to me as I look at the literature, the published literature about how people cope with an incurable condition and how people approach conceptually, behaviorally, psychologically their own mortality, is that almost all of this literature is focused on the very end of life. And it's a shame. There is a gap here, right? We heard this morning, you all are left out of the conversation about cancer treatment and survivorship to a large extent. And it's not appropriate to have, for the vast majority of you, conversations that are only viewed through the lens of end-of-life care. There is from 1 to 15 years or whatever we saw this morning in between. And so what I want to do next in the last couple of minutes, and then I'm going to stop so that we have time to answer any questions, is just talk about one particular lens that you can look through this existential crisis, and that's what it is. So, how many of you have heard of Kierkegaard and know about existential philosophy? Okay, great. So we don't have time to get into a long philosophical discussion, but this Danish philosopher is widely considered kind of the first person to usher into this notion of existential philosophy. The notion, basically, it's complicated, but the basic notion is that these are issues that deal with our own sense of who we are as individuals within a larger context of the world. These are questions about fundamental meaning. What is our purpose in life? There's a beginning, a middle, and an end. Are we born alone and die alone? To what extent are we connected to other people? And it's a very rich, interesting philosophical tradition that aims at these core concepts. And in fact, it's spawned a type of psychotherapy called existential psychotherapy, mostly proposed, the main proponent has been Irv Yalom. And for those of you who have an interest in a stomach for this kind of work, which I think is really fascinating, I would recommend a book called Staring at the Sun. The basic notion there is that while the physicality of death destroys all of us, the concept of death can actually free us up in some ways if we can kind of struggle with it. So there are two kind of second-generation versions of this kind of existentially oriented psychotherapy that are worth talking about for a minute. And they are meaning-centered psychotherapy. Bill Breitbart at Sloan Kettering is a psychiatrist who has done most of this work, and then dignity therapy by Harvey Chachinov, who's somewhere in Canada, I can't remember where, Winnipeg maybe. So essentially in meaning-centered psychotherapy, this was really driven by actually a book and some other works by Viktor Frankl, who was a Holocaust survivor, who fundamentally struggled with the idea of finding meaning even in the worst of possible circumstances. That was what was life-affirming. That is what made it tolerable when in every other respect it wasn't for him. And at the heart of this is connecting to something greater than ourselves. And this is what I meant right at the beginning when I said, you all have already figured this out because you're here. This is bigger than any one of you individually. This is meaningful. This can have consequences, maybe for some of you directly, if not for some of you, maybe for your sons and daughters, maybe for kind of a whole range of different studies that you can't even imagine right now. This is a version of what Irv Yalom talks about when he talks about rippling effects, which is, you know, since none of us lives forever, in what ways do we live on in the memories and thoughts and kind of hearts of people who come after us? When I see my daughter, who's a game player and likes to play cards, I see my grandmother, who was just loved bridge and mahjong and was just kind of couldn't stop playing games, and that's a rippling effect that I think has her living on. Dignity therapy is something a little bit different, and it's interesting. And this was developed as an end-of-life, brief psychological intervention that involves life review. When people come to the realization that this is the final chapter of their life, kind of what is it that you might be able to do to promote that sense of meaning and importance. And what's involved is addressing some of these existential concerns through an interview that's essentially it's a taped interview that creates a document that then is called a generativity document that people give to other folks. Now, to be perfectly honest, it's a little stilted. I've tried to do it a few times. But what I really like is the concept behind it. And the concept behind it kind of is reflecting on your life, is taking some time to think about what were the things that were most important. And it doesn't have to be done in a taped interview that generates a document. This can be done in conversations with a shrink or with a best friend or with a spouse or with anyone who you feel you can be straight with about what is happening. But these are the kinds of things that are interesting to reflect on in a time of kind of quiet when you're realizing that there are some things that you want to say to people who matter to you. Life lessons, advice, kind of anything else that you think is important for people you care about to know about. Now, in an analogous fashion to what's happened with palliative medicine, palliative care, which for a long time I think was unfortunately thought of as synonymous with hospice care. The palliative care movement has very appropriately shifted the curve way to the left, so that, as someone said this morning, why are we waiting to have an aggressive symptom management approach when people are dying? That should start when people are first diagnosed. All palliation means is you're decreasing the intensity and of the symptoms and the kind of difficulty with functionality. I think that this kind of work ought to happen way before any of us are about to die. Because I think what it does is it helps you step back and think about the core questions that matter to you. What am I doing with my days? Who am I doing it with? What's important to me? What do I think is going to matter after I'm gone? Who are the people that I need to connect with and share what kind of information? And so, again, I'm not suggesting that everybody get into psychotherapy because you have metastatic breast cancer. I think the vast majority of people, vast majority of you cope very well. These are concepts, though, that I think are relevant for the intrapsychic activities for people that matter. Now, I'm going to stop in 1 minute. I want to mention two things before I do. The first is, you've heard this now 4 times this morning. Leeza is modest. I think that she's one of the leading people in the world who is taking seriously what the supportive care needs are for parents with advanced cancer. And this is, in my opinion, an almost completely ignored thing. And so I think that it's critical that we all embrace the research agenda, and you need to inform this with us. And the last thing that I want to say is, as you're filling out cards, and we've got plenty of time for questions, that was by design, it doesn't have to be about the psychology of this. We're both psychiatrists. Or as my daughter once said when she was 6 years old talking with her friend, she puffed out her chest and she said proudly, "My father is a psychiatrist." We do prescribe drugs, and we're happy to talk about how you know what is normal sadness versus what is major depression, what kind of things you should think about for sleep and for anxiety and panic disorder and so on. So I thank you for your attention, and I'm looking forward to some questions. Come on up. First question is, how are NIH funding cuts affecting UNC research? Significantly. Significantly. I think that I just read an article last week that talked about how unless something changes, we have kind of created an unsustainable research enterprise where it's predicated on the notion that funding is going to keep going up and up and up, and what's happening to a whole generation of postdocs and junior investigators. I think that, as I said earlier, I'm clearly biased, but I think there is tremendous hope and tangible results that come from biomedical research, and I think that this is a great return on our investment. All of you who have letters and kind of computers, you should write to your congressman. You should let people know that, that we need to do more funding. It's a problem. It's really been tight. We went through a wonderful period where there was a doubling of the NIH budget for several years in a row. And there are always going to be cycles of this, but it's a pretty scary time right now. People are working very hard to keep their good work funded. Do you have one?
Yep, there's a bunch.
Here, let me share with you.
We're just going to start throwing them on the ground. All right. Okay. I'm just trying to find a grouping or similar. So one of them was, what types of support groups does UNC offer to caregivers of partners, spouses, friends living with metastatic cancer? And I think similarly it was looking at what does UNC offer for group support for those living with metastatic breast cancer? The answer is, I think we need to do more. This is a good opportunity for me, because I forgot to say it earlier, is that we actually are starting a group for those who are living with metastatic disease. I think it's called Living Well with Advanced Cancer or something similar, but it actually starts next week, and it's going to be going on every week for, I think, a couple of months.
Is Liz in the audience?
Yeah. All right, Liz is not here,
Okay.
but Liz is the one who facilitates it, and she's excellent. And I encourage those of you who are local and feeling like you are willing to make a trip down to UNC. It's not at UNC, it's at one of our satellite locations, so you don't have to deal with a parking deck. That would be one A. We also have a formal caregiver support group that's offered twice a month in the hospital itself for caregivers. And I think we have a lot of folks whose caregivers from the bone marrow transplant team come, but we would love to have other caregivers from other diseases as well.
Okay.
So, that's a good question. You want to take it?
Yeah. So the question is, what do I think about using pot? What was the question again? Oh, lighten up. It's so one of the nice things about no longer working for the federal government is that I can speak my mind. What I think is that Marinol is only minimally effective for some of the problems with nausea and poor appetite, and this is what we use all the time. I think the studies in the setting of medical illness are very compelling to me. They're clearly very compelling to the New York Times editorial board. Boy, am I going to get in trouble in a minute with what I'm about to say. I actually think that my personal belief and professional belief is that there is great utility for medical marijuana in the setting of advanced cancer. And Leeza's early in her career. It's, you know, well, so, no, I'm just...
I think most of our patients are using it anyway.
Right. That's right. What I would say is if you're going to use marijuana, use it intelligently, meaning many of you are immunocompromised. There's all sorts of fungal and fungi involved in, you know, in marijuana, and you can get pulmonary infections that are really life-threatening. And so I don't mean to make light of it. I think the pharmacologic effects of THC, I think, are very compelling. You got to be really careful about how you ingest marijuana and so on. So if you're immunocompromised, be very careful with how you do that. All right. Do we have another one?
Sure. So next one was, oh, that's right, never mind. How do you go about educating oncologists on psychiatric or psychological issues of metastatic breast cancer patients? They're the ones who are delivering the bad news. So I think this is an ongoing line of research for our colleagues as well as myself. And I think the answer really lies in you, in that if, you know, there's been so many times where I've talked to patients and I've said, well, have you told this to your oncologist? And the answer is, no, I don't want to bother them. You know, they're not here to help me with some of these issues. And I actually think that most oncologists do want to hear this, that oftentimes it can have great impact in terms of your treatments or kind of how you think about what other effective therapies are available. The first place to start is for patients to be actually discussing this with their providers. And that's the main thing I would say for that.
Mm-hmm. So I'm going to give a partial answer to this next question and then encourage whoever wrote this and others who are interested to tomorrow morning to go to a session with another one of our colleagues. Justin Yap is going to talk about kind of pediatric aspects of metastatic breast cancer. So the question is, what age is ideal to begin a young child seeing a psychologist regarding this disease? And I'm assuming what this means is a young child who's dealing with a parent with this disease. Is that what's meant? Okay. It depends. You know, it all depends on all sorts of factors. And one of the things that is crystal clear is that there are general developmental differences and individual developmental differences that matter. And so, you know, as a general rule, very young kids are not going to understand the nuances of what's different about having metastatic disease and kind of what that, I mean, it's hard for us to understand. And so I probably wouldn't have detailed conversations with kind of kids who are 3, 4, 5, 6, you know, about, you know, depending, and it also depends on where you're at in your disease trajectory. I also know that most kids, by the time parents get around to talking with them about this, they've already been thinking about it and they're not surprised by it. So my guess is that more times than not, a conversation earlier than later is going to be important. But there are some kids who are remarkably mature and ready for this, and others you have to be much more careful with and more vulnerable. So I would actually talk with your oncologist, talk with a mental health professional, you know, if you're really struggling. And clergy as well. Tomorrow morning, again, Justin Yap will be here, and this is what he does for a living, and there'll be a breakout session in the morning, and I would see what he says about that. One more, Leeza.
Because what are your thoughts about taking antidepressant drugs? I was given it when I was first diagnosed. My doctor said almost all of my patients that are metastatic are on something. Okay. I actually don't know what the data is, but I should. This is my own biases in that I think there are roles for medications, but I think particularly in this context, I would encourage everyone to not just settle for taking a medication only. Indeed, whether someone has metastatic cancer or not, if you just look broadly at the data, the people who have the best outcomes are those who often will who have medications, but along with some other form of intervention, and whether that is going to be talking, groups, exercise, acupuncture, whatever it might be, that really, that I think that's the part that sometimes get left. It's not just about taking Prozac. It's about Prozac and what else do we need to do. And I really don't know what else to say in terms of that part.
Let me just add one more thing and then we'll stop. We take a very medically oriented approach to this. We think about this, as I suggested earlier, as a version, our version of palliative medicine. So that when I was trained, you never would think about starting someone on an antidepressant unless they met all of the full criteria for the DSM, criteria for major depression, because the idea was you either had a real biological depression or kind of a reactive depression to something difficult in your life. And the fact is that that doesn't really matter so much. The only thing that matters is, are there symptoms that are getting in the way of you living your life the way you want to live your life? If you can't sleep, if you can't concentrate, if you can't get through a conversation with your best friend without bursting into tears, and a medicine might help minimize those symptoms, then even if it's for limited symptom alleviation, I think it's worth a try. And there have been some patients that will start on a medicine like mirtazapine or Remeron when they're not that depressed, but they can't sleep and their appetite is terrible, and those two things get better with Remeron. And so it's a conversation to have, but I would decrease the threshold and the stigma for what does this mean if I have to take an antidepressant. But what Leeza said is absolutely true. Study after study, combination of some kind of psychosocial intervention with medication for serious mood symptoms is better than one or the other alone. Thank you.